Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your top source for on-the-go radiology board review. This episode will cover high-yield facts regarding gestational trophoblastic disease. That is a topic that is often tested on radiology board exams. As a reminder, please follow at RadRevPodcast on Twitter or Instagram, where I post things like physics tips for radiology board exams. I will make a free downloadable study guide on the topic of gestational trophoblastic disease available on my website, www.theradiologyreview.com, so make sure and check that out if that is something that might be helpful for you. Without further ado, let's get into the questions and answers for this episode. First question: what is the purpose of the trophoblast in a normal pregnancy? The trophoblast helps the embryo penetrate or invade the myometrium and establish the necessary vascular connection for a viable pregnancy. Trophoblastic tissue normally secretes beta-HCG and human placental lactogen. Understanding the normal function of the trophoblast is key to help us understand what can happen when proliferation of that trophoblastic tissue goes awry. And that leads us to the next question. What are the main subtypes of gestational trophoblastic disease? Common subtypes of gestational trophoblastic disease include a complete mole, and that is MOLE, or molar pregnancy, a partial mole, a coexistent molar pregnancy, an invasive molar pregnancy, and choriocarcinoma. A few other subtypes of gestational trophoblastic disease do exist but are very rare, and these are probably not high yield for the ABR core exam, such as an epithelioid trophoblastic tumor. Again, I would focus on the common subtypes, which are complete or partial mole, coexistent molar pregnancy, invasive molar pregnancy, and choriocarcinoma. Next question. Pregnancies in which age ranges are at higher risk for gestational trophoblastic disease? The answer is that pregnancies in relatively young or older age ranges for pregnancy are at higher risk for gestational trophoblastic disease, such as pregnancy under age 20 or over age 40. Next, how does gestational trophoblastic disease commonly present from a clinical perspective? The clinical presentation of gestational trophoblastic disease often includes gestational hypertension, hyperemesis, and a uterus larger than expected for age. Imaging then can play a key role to identify the presence of gestational trophoblastic disease. Next question. What are expected beta-HCG values in gestational trophoblastic disease? In gestational trophoblastic disease or molar pregnancy, the beta-HCG values are expected to be much higher than normal for a given age of gestation. Following treatment of molar pregnancy, serial beta-HCG testing is often performed until levels are no longer detectable to confirm absence of any residual disease. Follow-up beta-HCG may be performed for something like 6 to 12 months to further confirm effective therapy. Next, what is the most common subtype of gestational trophoblastic disease? The answer is that a hydatidiform mole is the most common subtype of gestational trophoblastic disease and accounts for something like 85% of all gestational trophoblastic disease. Next question. What are characteristic features of a complete molar pregnancy? A complete molar pregnancy includes molar pregnancy with absent fetal components. That is really key in order to tell a complete mole from an incomplete mole. If you have absent fetal components, that would be consistent with a complete molar pregnancy. Most complete molar pregnancies have a classic 46XX chromosomal pattern in which all chromosomes are derived from sperm that fertilized an egg that had no chromosomes. This is the most common form of gestational trophoblastic disease. On imaging with complete molar pregnancy, look for a multicystic vascular intrauterine mass that distends the uterus with buzzword imaging features that include things like bunch of grapes and snowstorm appearance. On MRI, the mass may have T2 bright cystic spaces, T1 bright areas of hemorrhage, and avid enhancement as these tend to be vascular. Coexistent bilateral theca lutein cysts may be seen. A complete mole has a risk of invasive or malignant gestational trophoblastic disease in approximately 10 to 20% of cases. Treatment often involves surgical curettage or hysterectomy, which would be followed by serial beta HCG monitoring, as we have already discussed. Next question. What are characteristic features of a partial molar pregnancy? A partial molar pregnancy would have a molar pregnancy that includes an abnormal fetus or fetal parts. Remember, a complete molar pregnancy has no fetal components. A partial molar pregnancy does have an abnormal fetus or at least fetal parts. A partial molar pregnancy has a classic triploid karyotype, which can be something like 69XXY, in which the chromosomes derive from an egg and 2 sperms. On imaging with partial molar pregnancy, the placenta typically appears much larger than expected relative to the size of the uterus, and you again see a multicystic mass-like appearance of the placenta. MRI may be particularly helpful to see the extent of myometrial invasion. Next question. What are characteristic features of a coexistent molar pregnancy? With a coexistent molar pregnancy, you would expect to see a molar gestation with a separate normal fetus, and therefore this is coexistent. You have a molar pregnancy and you have a coexistent separate normal fetus. However, complications are common with a coexistent molar pregnancy and would include things like preeclampsia, fetal demise of the separate normal fetus, and premature delivery. Next question. What are characteristic features of an invasive molar pregnancy? An invasive mole is locally invasive with invasion of the myometrium and tissues around the myometrium, which can include blood vessels. With an invasive molar pregnancy, you would expect local destruction and obscuration of the normal zonal uterine structures. Metastatic disease is not a classic feature of an invasive molar pregnancy, and that is a high-yield fact. An invasive molar pregnancy may occur in up to 20% of molar pregnancies. That brings us to the final question for this focused episode on gestational trophoblastic disease. And that question is, what are typical features of gestational choriocarcinoma? Unlike an invasive molar pregnancy, gestational choriocarcinoma is at risk for metastatic disease, with hematogenous spread and lung metastases being the most common site of metastatic disease. Again, an invasive molar pregnancy tends not to be metastatic. Choriocarcinoma is at risk for hematogenous metastases, and the lungs are the most common site of metastatic disease. The primary site of disease of gestational choriocarcinoma is in the uterus, and this may look very similar to a molar pregnancy, but may have more solid components than an invasive mole may typically show. Beta HCG levels tend to be extremely high with gestational choriocarcinoma and are above that often seen with a molar pregnancy. Approximately half of gestational choriocarcinomas arise from a molar pregnancy, although choriocarcinoma may also arise from a normal pregnancy or can arise following a miscarriage. Non-gestational choriocarcinomas also occur, and in the non-gestational setting, choriocarcinomas are more associated with an ovary as the primary site in young girls or postmenopausal women, or choriocarcinoma in the non-gestational setting can also affect the testes, most classically involving teenage to young adult males. Fortunately, choriocarcinoma tends to be very responsive to chemotherapy and may have a relatively favorable cure rate. That is enough for now. There is quite a bit to unpack in this dense topic of gestational trophoblastic disease. I will make a free downloadable study guide on this topic available on my website, theradiologyreview.com, so go ahead and check that out. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.